Okay, I'm going to record it to the computer. We're going to see how that plays out. Let me open up this. And then I have to add my pad. The Zoom call. I'm sorry, 1 second, guys. I'm getting it in. I just gotta get everything situated on my pad too. Audio, stay participant. Got it. And then share content, share screen. Okay. Perfect. All right. Can everyone see this okay? Just give me a thumbs up if you can see it. Okay. Great, great, great. Okay, so let's go ahead and get started. So today we're basically going to finish off with everything else. We're going to talk about complement, how complement works. We're going to talk about how immunoglobulins work with complement. And then we're going to jump straight into hypersensitivities, straight into the primary immune deficiencies. And then we'll talk a little bit at the end about autoimmunity. With that being said, majority of your questions is going to be from this lecture. Now, I say that because majority of this lecture is tying everything together between innate, adaptive, what happens if it's low, what happens if it's elevated. So a lot of the questions will come from this. Now, is that to say all of them will? No. I would say this is probably going to be about 60% with the immuno questions that you're going to get. It's going to come from this lecture. Okay. Now, with that being said, a lot of this stuff isn't going to be new after we get past the complement and the antibody stuff. Okay. Can everyone hear me okay? Okay, great. Now, let's get started. So you already know about the antibody structure. Nothing's new here on that. The only thing I'm going to talk about is a few extra functions that we haven't really discussed that you probably heard in your videos. I'm just wanting to state them just in case you may not have watched the videos pertaining to those. Now, these functions are this. One, complement binds to this. Okay, there's a binding spot on antibodies for complement. That is here at the C2 spot. Okay. Now, the other thing I really want to point out is what we were already kind of discussing last time with how CD16 is a big player with the antibodies. Why is that? What does CD16 deal with? Yes, it's the receptor for the Fc portion. So it's this receptor here is CD16. Okay. And that allows these macrophages, neutrophils, eosinophils, basophils to do their function. Okay. Now, they do that via one of these ways known as opsonization. Okay. Opsonization is essentially just taking a microbe, whatever microbe it is, and making that microbe more attractive for the macrophages and phagocytes to eat them. Okay. A good analogy I've used or I've heard as well is it's almost like taking a strawberry that's already like really good to eat, right? And dipping it in chocolate, and now you want to eat it even more, right? So the chocolate component would be the antibodies binding to um the microbe, right? Making it more attractive to these macrophages, these neutrophils. Okay, good. Now, the last one that they play with is neutralization, because I've already talked about the complement, right? this complement activation. The last one is this neutralization. Yeah, kind of like seasoning, if you want to think of it like that. But it's by whichever one you gotta think, it's making the microbe more attractive to eating. Now, neutralization, essentially what it does is that it binds to certain portions of the microbe. Because these microbes, when they float around, right, they got certain receptors on them. And these receptors bind to portions of your cells and allows them to be um, kind of endocytosed, like brought into the cell. Okay. So if that doesn't happen, then you're never really getting infected, right? You have to get this microbe or virus to get inside of the cell for you to actually kind of have um, this infection, right? With viruses. With microbes, it's not so much because they actually like kill off cells. But with viruses, that's what it is. Now, but with that being said, these binding things that bind to your cells, they can be bound by antibodies. So then in that sense, they can no longer attach to cells and they can no longer be endocytosed into cells. Okay. Therefore, preventing you from getting sick. Does that make sense? And this is known as neutralization. Now, neutralization is really big when it comes to toxins because that's what really is a big player pertaining to like snake bites, pertaining to what else is a very good one? Like tetanus toxins and stuff like that, like toxins that microbes make. Neutralization is a big player in that and helps with preventing you from having certain symptoms. Okay. So that's the other thing that neutralization deals with, not only targeting microbes, but even toxins that these guys produce. Okay. All right, good. There's nothing else I really want to hint on other than the guys that do complement are IgG and IgM. None of the other ones deal with activating complement other than IgG and IgM. IgA doesn't do it. IgE doesn't do it. Okay, it's only these two guys. All right, good. And now that this is a thing that we've already kind of talked about, and I wasn't really going to talk much more about it than that IgM and IgG are very big for complement, and you can see that here, fixes complement. And then for IgM, fixes complement. But you don't see that in any of the other guys. Okay. I guess other things that we can ask to kind of tie this together. Which one of these do you think would be really good for neutralization? IgA, IgM, IgG, or IgE? What do you think would be really good for neutralization? Okay, so IgM, IgG, IgG. Yeah, so the big one that deals with neutralization is IgG. Now, the reason why I'm saying that is because IgG is very high affinity, right? You want something to bind very strongly if you want to neutralize it. Okay. Now, with that being said, though, however, if you start thinking of things like activating complement, which one do you think is better, IgG or IgM? IgM is better. Why is IgM better? Yes, perfect. Do not forget that. You have 5 FC portions that you can utilize versus the 2 FC portions, or the 1 FC portion you get with IgG. So that's a big difference. One is very good for neutralizing toxins and viruses. One is very good in activating complement. Okay, good. Any questions on that before we move on? No? Okay. Now, those were just the extra bits and pieces that I didn't talk about last time. Now, complement. I've already said already, right? IgG, IgM is the big player. Make sure you remember, once again, IgM is the guy that's more common to activate complement. That doesn't mean IgG can't do it. It's just that IgM's better at it. Okay? Now, there's different pathways you can utilize to activate these complements. Can anyone tell me what those pathways are? If you've already watched the video, I want to see. Yes, there's an alternative pathway. What else? Because there's 3 of them. The lectin pathway, good. And then the classical pathway. Good, good, good. Now, my question to you is this. Which one of these deals with IgG and IgM mediated? Good. Yes, the classical pathway. Okay. So whenever you think of IgG, IgM, always think you're activating the classical pathway. Okay. Lectin, like you said, it has to deal with binding to some kind of sugar, right? A lectin on it. What does the alternative pathway deal with? Yes, so it's mainly essentially a spontaneous one. Something on sorry, something on the surface of microbes causes these complements to spontaneously break and form this this protein known as a MAC complex, MAC. Okay, a membrane attack complex, which we'll talk about. With that being said, what is MAC mainly used for? Because you need to know the goal now. We now know what activates it, but what is MAC really used for? What type? Gram-negative bacteria. Perfect. This is also a very big thing to remember. Is gram-negative? Because, and this is something that we're going to discuss more on when we do microbes, right? You got gram-positives and you got gram-negatives, okay? In gram-positives, you got this big cell wall, okay? And then you got the cell membrane, and then you got the matrix inside, okay? In gram-negatives, you got a very small outer membrane, followed by um, just kind of a space, and then you have an inner membrane. Okay, now this space here is where you have various proteins and stuff like that. However, because of how small of a space this is versus this is why you're able to easily punch holes in it. Because think of it like this. If you had this big old wall, it's hard for you to just make a small little opening here on the top and that be able to pierce all the way through the wall, right? Because these proteins are only so, I guess, long or depth wise that they can't span that whole cell wall. But here, the depth wise is enough that it can span the whole outer membrane and puncture gram-negative bacteria. Okay? So if you had an issue with the MAC complex formation, you would suspect to have increase in gram-negative bacteria. Does that make sense? All right, perfect. And you'll see that as we move on. Now, with that being said, you have all this formation of these proteins, right? Cleaving to form the MAC. We're going to get to this here in a minute. All these proteins to form MAC, right? You need some kind of way to deactivate it because just like in the immune system, right? When we talked about activation of T cells with activation of B cells, it's a huge positive loop, right? Th1, they release interferon gamma that then further produces Th1, right? Th2, they release IL-4 that further produces Th2. Okay. In this scenario, it's no different. There's a positive feedback loop. Okay. You're constantly activating more and more complement. So you have to have some kind of way of stopping this process. Okay. Now, there's a variety of ways that we do that. One is we have certain things on the surface of cells, which is known as the decay accelerating factor. What this thing does is it's located on the cell membrane. So when complement comes by and tries to bind to it, essentially the decaying accelerating factor knocks that complement off. So then you no longer have complement on the surface anymore. Okay? So then that specific cell doesn't die. Now, these cells have to have CD55 on them present to do that. So not all cells have that, right? Especially bacteria. They don't have CD55, which is why they're not able to push off complement. They have other things, and you'll learn that later, that do the same kind of action as CD55 and prevent them from dying from things like complement, preventing them from dying from things like antibodies, so on and so forth. Okay. Not important to talk about right now. But you will learn those things. Now, the other thing that's really big is this C1 esterase inhibitor. This helps to prevent complement from activating normally on the surface of the cell. So you got one that knocks off complement if it's already activated, and you got one that prevents complement from be activating from the very start. Does that make sense? Okay, perfect. Now, let's go into the actual process of these complement pathways. So, you guys already know, because you guys have watched the videos, right? Pertaining to complement and the different types of complements. So now let's go over and discuss the functions of this pathway. So you have three pathways. 1, 2, 3. Do you need to know all of them? Yes. Do you need to know all the details? Not so much. You do need to know which one is stimulated how. For instance, you need to know that alternative is stimulated spontaneously on the surface membrane of bacteria. You need to know that lectin has to do with a mannose or a sugar on the surface of a microbe. Okay. You need to know that the classical pathway deals with antibodies. Okay. Because they could give you a vignette where a patient is hypogammaglobulinemia, so they have low antibodies, and then they ask you something along the lines of this complement pathway. And they're asking you like, this patient is still able to produce complement and produce a MAC complex. How is he most likely able to do this? Or which pathway is it utilizing? Something along those lines, right? So you still have to know what these pathways are. Okay. I'm not going to harp on each one of these. I'm just going to show you the main important things. Now, the main important things to know is that C3b is what? Let's see if anybody knows. What is big about C3B? Okay, it's big in all three. Yes, it is big in all three. That's not that big of a marker to really worry about. It's more of that essentially you activate C3 convertase, right? But C3b is an opsonin. This is a biggie. Okay, so it binds to the microbes and allows these microbes to now eat them up. Okay, the other big thing to know is C5a. C5a plays the same kind of part as IL-8. If you remember, IL-8 deals with chemotaxis of neutrophils. Okay. C5a also does that same thing, chemotaxis of neutrophils. Now, there are other guys, leukotrienes, that do the exact same thing. When we get there, we'll talk about them. I have that saved up within the farm portion. Okay. It's leukotriene C4D4E4. These guys also deal with chemotaxis and bringing in, right? Um, but we'll get there. Okay, and I'll show you that. Because it's hard for you to kind of be like, well, what's going on with these guys? Like, where they come from? And we'll also talk about it in pathology as well. Now, from there, you then have C5b all the way to C9 that forms this MAC. And MAC, like we said, pops holes in gram-negative bacteria. Okay. Any questions on that so far? Okay, great. So the last thing I want to talk about is what is known as anaphylatoxins. Can anyone tell me about what these guys are? Anaphylatoxins. So anaphylatoxins are toxins that, yes, they essentially activate mast cells. That's the big thing, right? They activate mast cells that then cause them to release histamine. And this histamine then causes you to have things like anaphylaxis. Yep, perfect. Um, and yes, you are right. It's all the A's, right? C3A, C4A, C5A, okay? All the A's with anaphylatoxin, okay? Now, there are a variety of other things that cause anaphylaxis, and when you go through the semester, you're going to hear those ones as well. Stuff like radioiodine that they inject you with to see the imaging, that's also an anaphylatoxin and can stimulate mast cells, which is why people end up getting hives after they get certain radio imaging, right? Another one that's very big in that is like opioids. Opioids can do the exact same thing. They can stimulate these mast cells to degranulate. Okay, so there's a variety of things that can cause it. Okay. Um, and you'll go over that. No, so overdose is not really what this is getting at. It's more of um an additional side effect or additional symptom that can occur because of them being anaphylatoxins. Okay, good, 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 good. Because overdosing is like a whole nother aspect. And we'll talk about, actually, we may talk about it a little bit. Okay, so outside of that, the last thing I want to talk about is how these opsonins, C3b and IgM, these guys are really big in opsonization, right? Oh no, not IgM, IgG. These guys are really big in opsonization, right? So the last thing I want to say is these two guys, they help eliminate what is something called immune complexes. Now, what is an immune complex? Well, let's go over this a little bit. So immune complexes are this. Here's my antibody. Here's an antigen. And you get a whole bunch of antigens, right? And you have a whole bunch of or not immune complexes, but antibodies. Essentially, what ends up happening is they bind to these antigens, right? And when they bind to the antigens, they tend to cross-link because some antibodies may bind to the same antigen. Okay? So it's like you're grouping them together. Now, this is very important when it comes to your immune system because if you group things together, it makes it less soluble in the fluid. So it makes it easier for things to eat it up. Okay? It's just the same concept with um like taking salt, right? Or sugar and you pour it into a water glass. If you condense the water down, then you start precipitating out sugar crystals or salt crystals. It's the same concept, right? So these substances start to um, become less soluble in the blood. However, this is also a bad thing because what can end up happening is this can end up being stuck in various areas where you got filtration occurring. Okay. Or tight capillaries. Okay. So things like blood vessels can get damaged. Things like your kidneys can get damaged. Things like your synovial membranes can get damaged, like in your joints, right? Because you make that synovial fluid by taking your blood and passing it through a grate, essentially. That's essentially what you're doing when you make synovial fluid. And those immune complexes get stuck in them. Okay. Any questions on that? Okay. So you're essentially making immune complexes, once again, whenever you have antibodies binding antigens. Okay. Whenever you got antibodies binding antigens, you form immune complexes. This can happen in a huge variety of infections. This can happen in a lot of drugs that you give. Anything that has antibodies binding to an antigen, you can possibly have this occur, these immune complexes. Does that make sense? Because this is kind of the segue into hypersensitivities. Or not hypersensitivities. Yeah, hypersensitivities. I was right. Okay, great. So this is just breaking down again. This is the cell, and you've got various receptors on them to do their various things, right? The CD55 that knocks complement off. You got B7, MHC1 that deals with coactivation, right? B7 is also known as CD what? Eighty, 86. CD25 that you're thinking of is the receptor for IL-2. Okay? So that's what that is. CD25 is that receptor. Yes, there you go. It binds to CD28. Yes, you are right. It binds to CD28 on the respective T cell. Great, great. That was the next thing I was about to say. Um, so that's what that is. Okay. Can anyone tell me what this PDL1 is? What is that guy? Do you guys remember? We discussed it. Yes, great. He's like the inhibitor, right? He's the guy that tells T cells, please don't kill me, right? Even if the T cells see a foreign antigen, right? So this is the off switch. So what happens if we form an antibody that binds to the off switch? What will happen? So if we create an antibody that binds to the off switch and prevents it from interacting with its own receptor, PD1. Yes, we kill the cell. Perfect. The cell that we ended up trying to save or is trying to save itself, this cancer cell in particular does that a lot in solid cancers, but either way, they end up dying. Great. Now, the next thing is there was another, since we're talking about these guys, there's another guy that had to do with mediating the immune response and decreasing their immune response. Do you remember? It has to deal with this guy. So Tregs do present this, but I'm looking for the name of the inhibitor. So FOXP3 is the name of is like the actual marker for the T cell, the Treg cell. C1 esterase has to deal with the complement pathway, not dealing with the regular immune response with the adaptive immune response. Do you guys remember this guy, CTLA4? This is the guy that binds to B7 or CD8086, right? He binds to it, and as a result, it prevents the cross binding of CD8086 or B7 with CD28, right? So if these CD28 and B7 don't bind, then you're no longer given the secondary signal to the T cells, so then they turn off, right? And then we even talked about, okay, what happens if we produce something that binds to CTLA4? What does that do? So if we have an antibody that binds to CTLA4, yes, so it causes the body to stay active, right? Because CTLA4 inhibits and stops the production of the immune response. But if we produced antibodies that were like CTLA4, then we stop inflammation because the CTLA4s would bind to B7 and prevent activation. Make sure you know both sides, okay? Because they could throw you a question on either side of the road, okay? But essentially, more often than not, they'll say that CTLA4 is the antibody they give you because it's more used for anti-inflammation, like decreasing inflammation, than keeping inflammation. This one's more for decreasing. This one's more for increasing. Okay. This is a more common way that you're going to see it. Yeah, like rheumatoid arthritis, things like that. Now, rheumatoid arthritis has a variety of other things that are used for it, like TNF alphas and stuff like that. Even drugs that to suppress your immune response entirely. So it's not just this drug, that can be used for rheumatoid arthritis, but this could use for it as well as for psoriasis, which is also a immune aspect of things. Now, with renal transplants, remember we talked about this pathway, CD25, IL-2. This is mainly where renal transplant come into play because you want to stop the immune response from even starting. Okay. So that's why you use those guys for those conditions like transplantations, IL-2 blockers, and stuff like that. Yeah, you prevent proliferation. Exactly. And we're going to talk a little bit about them today. And yes, there are so many immunologics, um, but take it bit by bit, right? And really focus in on where would you use this? Okay. Where would I use this? Oh, I would use this in renal transplantation. Okay. Like cyclospora and tacrolimus, all those guys. We'll talk about them. All right. So now let's talk about a condition that has to deal with a damage to the C1 esterase inhibitor. So C1 esterase inhibitor not only does a little bit with complement, but also does a little bit with bradykinin. Bradykinin is a big player in forming swelling. Okay. Swelling everywhere. Okay. Your mucous membranes, your skin. Okay. It's not like histamine, that's more the skin surface. You can get it inside and get mucus involvement, but that's only if you have something like anaphylaxis, right? Um, so this is more of a vascular portion. Now, with that being said, you can see that how C1 esterase inhibitor, what it essentially does is it stops the production of kallikrein. Kallikrein is a liver-produced enzyme that is formulated from prekallikrein. Whenever you have your immune system activated, this process gets activated as well because this prekallikrein and kallikrein deals with activation of complement. So that's why this also gets activated in just regular infections. Okay. So it's not like this guy is only in certain situations. He's in a broad variety of things. Viral infections, bacterial infections, even just trauma in general, kallikrein comes into play. Okay. However, the big thing kallikrein does is that he takes high molecular weight kininogen. That's what this is. High molecular weight kininogen and turns it into bradykinin. Bradykinin is the guy that goes and does everything that we have here. Okay. Any questions on that? No. Perfect. Now, here's the next thing. So, there's an enzyme known as angiotensin converting enzyme. that is responsible for breaking down bradykinin. Okay. Yes, perfect. It's found in the lungs. However, it is found in other places than the lungs, but more prominently for this condition, it's found in the lungs. Okay. You have a huge array of enzymes all over the body. That's why you always see like 1, 2, 4, and all that stuff with receptors. So, anyways, um, yes. So this enzyme can get blocked. Okay, this is where ACE inhibitors come into play. You're going to talk about those in Med 4 when you talk about cardio drugs, but this is where one of the conditions comes into play. So ACE inhibitors essentially block this enzyme from working. So if you block this enzyme, what do you suspect would happen? Um, Not so much low BP. I mean, yes, you do get low BPs. You can. Yeah, that's the big thing I want you to kind of get away. So a lot of you guys are kind of pulling your knowledge from old people telling you about what ACE inhibitors can cause, right? Which is great and I love it. Um, but at the same time, right, we want to make sure that yeah, that's for that, but it could be what's going on here because this is the more important thing. And this is a very big reason why you don't prescribe ACE inhibitors. So what essentially happens is this. ACE blocks bradykinin from working. And as a result, bradykinin builds up throughout the body. Okay. So bradykinin then causes things like vasodilation of blood vessels everywhere. It causes increased permeability everywhere and can cause pain as well. But the vasodilation and increased permeability causes what is known as edema. And this is what we know as hereditary angioedema. Okay, so there's two different ways you can get this same condition. One is that you lose C1 esterase, or two, you block ACE inhibitors. Okay, any questions on that? And from there you present exactly the same. You have swelling in your mucous membranes all over your body. You can have difficulty breathing. Essentially, it's no different than an anaphylaxis presentation. Okay, are we ready to move on? All right, perfect. So with that being said, here's a picture of it, and you can see how you have this massive swelling noted throughout the body. Okay. And your lips and your oral cavity is all mucous membranes, which is a big component of hereditary angioedema. All right. All right, good. Now let's continue. Next thing we're going to talk about now is hypersensitivities. There's four of them. Type 1, type 2, type 3, type 4. Okay? They have different protocols or different um requirements behind them, right? So for instance, type 4 is always adaptive immunity, CD8, CD4. Okay? Type 3 is always immune complex led. Type 2 is always antibodies binding to the cell. Okay, and we'll talk about that. It can be the cell themselves or the cell wall. It could be inside tissues, but it's always the antibody binding to the tissue. Okay. Type 1. This is the one that you're most familiar with and is always the easiest to see. This is the one that you see like bee stings and they show up with swelling and body itching and hives and all that stuff, right? So whenever you think of allergic reactions, that's technically your type 1s. Okay. That's how these four are broken down. Okay. Now, with that being said, type 1, type 2, type 3 are antibody-led. Type 4 is adaptive immunity-led with CD4 and CD8. Okay. So, with that being said, which one of these do you think is going to take longer to work? The guys that are antibody-led or the guys that deal with adaptive immunity? Yes, type 4. And that's exactly the same concept moving forward. You're going to see that adaptive immunity is a guy that takes a long time after you've been exposed to it to present symptoms. Okay? Versus type 1, type 2, type 3 have antibodies produced. So after the antibody is produced, the symptoms occur almost instantaneously. Okay? Good. Now, it may take a minute for the antibody to produce, but after they produce, you produce with symptoms. So here's the picture. Let's work these things through. Just like I said, type 1 has to do with antibodies, same as type 2 and type 3. What antibody are we dealing with here? IgE. So essentially, this is what happens. The first time you get exposed to something that you are allergic to, let's say pollen, okay? Pollen or copper is another one that people get allergic to, or even a drug, okay? Let's say like amoxicillin or augmentin, something along those lines, right? The first time you get exposed to it, you get what is known as sensitized. Now, what sensitized means is your body produced the IgE. It produced IgE, which then bound to the mast cells. So you are essentially sensitized now to this antigen, pollen, whatever. Okay, does that make sense? Yes, perfect. Now, the second time you get exposed to it, this is when you actually have a reaction now. Okay, that would be the anaphylaxis. It could be hives. It could be any of those things, guys, above, right? Now, the repeated exposure is like a cyclic process because you increase IgE, which then makes the next response even worse than the last one. That's usually why whenever you get stung with a bee and you have a mild exposure and you're like, oh, it's a little red there. And then you get stung again and it's like really big. You're like, oh, yeah, I got a little bigger. It's a lot worse. And then they're like, okay, you need to just stay away from getting stung by bees because the next one will be even worse because you're constantly forming new IgEs and more IgEs are then causing you to become more and more sensitized. Okay? So here comes the next question then. There's people that get what is known as exposure tests. They go and they get pinpricked by various allergens to help decrease their allergies, right? How does this work? The way this works is this. As you are continuously exposed to it at very low levels, we're not talking about big, huge doses here. Okay, we're talking about very low levels. The other antibody you continuously produce is IgG. So essentially what you're trying to do is you're trying to have enough IgG present that it soaks up everything before IgE can even see it. And that's how that works with that process. Okay, good. Any questions with that? Now, we're going to keep moving on a little bit more with this. So mast cells, they do the initial response. They produce histamine, and they also produce what is known as tryptase. Tryptase is your big marker to tell you that this person had an anaphylactic or a histamine mast cell reaction. Okay? Because tryptase is only really, released from mast cells. Okay, and is a big marker from them. All right. Now, after histamine is released in this tryptase, you also have a variety of other things that are released. For instance, you release things like IL-5. IL-5, brings in eosinophils. So eosinophils come in during the late phase because you got to think IL-5 has to be produced. IL-5 then has to go and stimulate eosinophils. Eosinophils then have to travel to the tissue. They have to extravasate out of the blood into the tissues before they actually then can cause symptoms. So it takes time. So this is what is known as the late response. You have the initial response, which is due to mast cells degranulate, and then the late response, which is due to eosinophils. Okay, with them releasing what is known as major basic protein, which damages the tissues. Okay, any questions with that? No. Okay, good. Now, the next one we're going to talk about is type 2. So within type 2, you have two different types or two different setups. One, you could cause cell death. You bind to it, and as a result, you cause apoptosis. You bind to it, you activate complement, and you cause lysis with the MAC complex. Or two, you cause what is known as cell dysfunction. You bind to it, and you prevent that cell from doing whatever it's supposed to do. Okay? Now, you've been exposed to a variety of things that were cell dysfunctions. For example, myasthenia gravis. That's an example of this. Antibodies bind, and as a result, you can't activate the muscle. So it's a cell dysfunction. Okay? Lambert-Eaton or myasthenic syndrome, same thing. Cell dysfunction. Okay? It could go on to the other side of things, and you can look at things like Graves' disease, where you're activating the cell, okay, versus inhibiting the cell. Okay, does that make sense as we move on? All right, great. Now, the big thing here is it's binding to the cell. Once again, binding to the cell. It doesn't make immune complexes and then get filtered out. It actually binds to the cell. So that means that there's something on the cell that the antibody is looking for. Okay? All right, good. Now, we've already talked about how we can have blood cell destruction, like we said, and how it can cause cellular dysfunction. Okay? Any questions on that? No. Okay. So the next one we're going to talk about is immune complex mediated. Now, this one, remember, has to deal with antibodies binding to antigens in the blood. These are free-floating antigens. Free-floating. So they're not attached to anything. They're free-floating. And as a result, they form immune complexes that you see here. What type of immunoglobulin do you think this is? IgG. Remember, IgG and C3b deal with forming immune complexes and opsonization. Okay? That's the big thing to make sure that you do not forget. IgM is big for activating complement. Okay? All right, good. Now, let's continue. So this is most likely IgG because that's the guy, once again, deals with forming immune complexes. So these guys get formed. And as they get formed, let me draw a picture. Here's my immune complex. Right? I'm going to do just 3 antibodies here. Now, as they get formed, they then get pushed through very tight filters in your body. So think of any location that your blood is pushed through capillaries, anywhere in the body, right? The kidneys, perfect. The skin, because you got capillaries in your skin with blood vessels, perfect. And last one is joints. So the typical symptoms you present with is this: nephritis, which means inflammation of the kidneys; vasculitis, which means inflammation of the blood vessels; and arthritis, which means inflammation of the joints. This here is the typical presentation when you have immune complexes. This never changes. Any condition that forms immune complexes most likely has these 3 symptoms because that's how this symptom works. Or condition, I should say, not really symptom. Okay? And once again, this is not binding to tissue. It's free-floating antigen. I cannot stress that enough. The reason why is because people have a hard time identifying this and this. People have a very easy time identifying this and this. It's the middle two people have a lot of hard time identifying because they're like, is this binding to the cell, or is this binding to something in the blood and then binding to the cell? So that's why I'm really stressing that type 2, it binds to the cell. So there's actually something on the cell that is foreign. Okay. Type 3, it's binding something in the blood that's foreign and then gets deposited in the tissues where you have filtration. All right. Now, the last one, I'm going to finish this and then we'll take a little break. The last one here is cell-mediated. Cell-mediated deals with, T cells or the adaptive immunity, particularly T cells. Okay. Now, what's happening here is this. On your cells, they present normal proteins. Right? However, there are various things that are too small to be picked up by the immune system that are foreign. These are what are known as haptens. Okay? So haptens are foreign antigens that are too small for the immune system to recognize them. Okay? Does that make sense so far? All right. Now, as a result, they bind to various normal proteins. So now it's big enough for the immune system to recognize it. This is why you get a CD8 and CD4 response. Because essentially it looks like this cell has a virus in it. Because you have an abnormal protein presented on the surface of the actual normal cell. Okay? So as a result, you get various things like blisters and vesicles that I'll talk to you about here in a bit. But this is why you get a CD8, CD4 response versus a antibody response up here. Here, it's too small for it to activate the immune system, which is why you do not produce antibodies. Okay? Any questions on any of that? Okay, perfect. So let's go ahead and we'll take a break real quick. Let's say 5 minutes. So we'll meet back at 6:10. And then we'll just zip through the rest of these slides because it's just rehashing what I've already discussed. Sound good? All right, guys. Am I moving too fast? Am I moving too slow? Are we going good? Okay, good. All right, guys. Take your little break, recharge your batteries. All right. Is everyone back? Ready to go? And push on forward. All right. Good, 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 good. Okay, so let's continue. So now let's just kind of look over these guys. It's not going to be anything different, right? So just like we talked about, anaphylactic, or this first one, so this is type 1, right? You have this fast initial phase, which is the immediate due to IgE, right? Pre-sensitized mast cells. So you had that sensitization stage, and now you have the secondary exposure, causes you to release things like histamine, like we said, tryptase, which is a big thing for mast cell marker, like we said. Okay. Now, the other thing is, like we were talking about, right, is leukotrienes. Now, these leukotrienes, which one in particular is important? Which leukotriene is very important? So, here with the leukotrienes, you got things like leukotriene D4, which is very big with vasodilation. And we'll talk more about this whenever we do path and how these factors play with the various stages, right, of acute inflammation. Things like fever, swelling, or tumor, stuff like that. So leukotriene D4 is really big in it. E4 is also very big in this. But the other guy is IL-5, this interleukin that stimulates eosinophils to come. And they release major basic protein, which causes the late effect. Okay? Now, here is type 2. And just like we talked about, there's a cellular destruction one. They bind to it and they cause death of the cell. Okay? Now, since they're binding to the cell, this is via the antibody-dependent cellular cytotoxicity. So via that FC receptor, CD16. Okay? So only cells that utilize CD16 can utilize this pathway. Things like neutrophils, things like natural killer cells, things like eosinophils. Those are the big guys that you think of when you think of cellular destruction. Okay? Via this pathway. Now, the other thing is when you have this antibody that's now bound, you have this portion that's now exposed for complement. So that's why complement system is also another way that you form these MAC complexes that pop holes in the cells and cause them to die. Okay? Now, you got a variety of conditions here that you can present with. We're going to go over some of these guys later. Now, the next one is just general inflammation, because the other guy that gets activated here that I said was neutrophils. And if you remember, neutrophils and macrophages, they produce those inflammatory markers at the very beginning. IL-1, IL-6, IL-8, IL-12, TNF alpha. Those guys, really big in the pathway. Okay? So those guys are also produced, that then causes inflammation to occur, and that then causes further damage to the area. Because neutrophils, they release their lysosomal enzymes, damaging the tissue. And then the last one is that cellular dysfunction that we discussed. Okay, and just like we were talking about, myasthenia gravis is right there. as well as Graves' disease, right there. All right. So any questions on this one? No. Okay. So there's two tests that you can do with this. And this is where Combs test comes into play. So there's a direct Combs test and an indirect Combs test. This is how it's broken down. In a direct Combs test, the actual cell you're looking at already has antibodies bound to it. Okay? So it already has antibodies bound to it to destroy that cell. The only thing is that complement hasn't been activated or neutrophils haven't showed up to kill off the cell yet. But essentially, that cell has been marked for death already. Does that make sense? Okay, so you got the antigen and the antibody present in the blood or on the cell. So essentially, all you do is tag it with a marker now. You tag it, which is what with this anti-human globulin or Combs reagent. And essentially what this does is it causes these antibodies and RBCs to clump together, which is what you see here. Okay? And you can see how these guys we've added are linking the red blood cells together. And what did I say? Whenever you link things together, you group them up, what happens? They precipitate out and you can see them. So that's exactly what's happening here. You're grouping them together so that it's going to precipitate out as agglutination. Okay. Now, I'm going to show you a picture of it real quick. So this is very important. So you can see it. This here is an example of agglutination. A is agglutinated. You see how there's clumps inside that tissue? It's because of those antibodies, right? Binding to them, causing them to group up. And it's agglutinated. It's literally pulling them out of solution. Versus B, anti-B, there's no agglutination because there's no clumping up of the RBCs. Okay? So this is a difference between agglutinated versus non-agglutinated. Good? Before we move on? Okay, good. Now, so that's how a direct Combs test is. Okay? Now, an indirect Combs test is when you do not have the actual antigen. There's no antigen in the body. You have antibodies, though. So you don't know if the patient has antibodies for the antigen you're looking for because you got to think, you got millions upon millions of antibodies in the body. What are you going to do? Sift through all the antibodies? No, that'd take too long. It'd be so much easier to expose them to the antigen that binds the antibody. So you would then see if it binds that antigen, right? So that's exactly what we do. We take the antigen that we suspect they may have an antibody for, we expose it to it so they clump together. So essentially what we're doing is we're causing this to occur. We're causing antibodies to bind to the antigens that we know or are suspecting the patient may have. And then we add in the corresponding anti-human globulin to cause it to then once again group up if it's present. Now, here's my question to you now. If a patient is positive for an indirect Combs test, does that mean that they have active breaking up of red blood cells? right now at this moment? No, exactly. Because these antibodies are not bound to the antigen. You've been exposed to it, but you currently do not have the antigen in your body anymore. Okay? Now, for a direct Combs test, do you think if you have a direct Combs test that you have active rupturing of red blood cells right now? Yes, exactly. Because you actually have the antigen present in a direct Combs test. So the antibodies bind to them and they rupture the cells. Now, here's my next question. You want to find out if a mother has developed antibodies against her fetus in the past, would you use a direct or an indirect Combs? Yes, an indirect. This is how you diagnose someone with erythroblastosis fetalis. Okay. You see if the mom has developed antibodies to the baby fetus. This is where this comes into play. Okay. So make sure you don't forget it. Direct, you have the antigen present. So you have binding of antibody and antigen. Indirect, you do not have the antigen present. So there's no antibody to antigen binding. So you have to expose them to the antigen to see if they have the antibody. All right, good. This is another presentation of the same thing we discussed. Um, okay, so that's tab 2. This is now type 3. So type 3, like we said, right? It has to deal with antibodies binding to things in the blood that are not cells, right? They're binding to little antigens present in the blood, not on cell, not on the actual cell wall or cell membranes. Okay. And then they deposit as complexes into the wall of various tissues. Okay. Now, there's also what is known as Arthur's reaction. What I just explained to you is also known as serum sickness. Okay. Where you develop this arthritis, this vasculitis, this nephritis. That's serum sickness, essentially. Okay. Arthur's reaction is a little different. So, if any of you guys are diabetics, you know, especially type 1 diabetic, you have to give yourself, you essentially inject it into the subcutaneous tissue. Now, the other thing is insulin is not formed by your own body. So essentially, this insulin you're injecting yourself with is foreign. Okay? Does that make sense? Now, over time, what ends up happening is this foreign insulin eventually initiates an immune response. Because you got to think, when you stab yourself with a needle, what do you think you're going to do? You're going to stimulate macrophages. Macrophages that get stimulated, they start presenting B7. They start gobbling up some of the insulin. They start presenting it to CD4 and CD8 cells, or not CD8, CD4 cells, to then do their job, as well as stimulating B cells to become plasma cells. So you eventually form antibodies. And if you remember, antibodies is part of the innate immune system. So that means you have antibodies present in your tissues, not just in the blood. So you inject this foreign insulin at this site of antibody production, and essentially they form immune complexes here. A localized immune complex. So what do you think symptom-wise you would present with? If you formed localized immune complexes, what do you think symptom-wise you would present with? So yes, you get arthritis, but let's go actual symptom-wise, right? The patient's not going to say, I got this arthritis reaction on my chest, right? They're going to tell you what it actually is, what it looks like. Inflammation. So you'll end up getting what is known as a vasculitis at that location. Okay. You will not get arthritis or nephritis because it is not getting into the blood. This doesn't happen. So as a result, you just get the vasculitis at the location. Okay. Because these immune complexes deposit in the blood, like on this blood wall here, which then causes inflammation to occur and you get vasculitis. So that's an arthritis reaction. All right. Good. Any questions on that? It's the same concept as immune complexes, is it's now localized to one location. All right, perfect. So this is showing you a serum sickness case. This is something that's widespread in the body. And just like we said, right, you're going to end up with that vasculitis, as well as you're going to show up with nephritis, as well as arthritis in this phase. Okay. Now, arthritis reaction, we already talked about it. I'm not going to harp on it anymore. You see this localized. This is a big word. Localized symptoms. Okay. No nephritis, no arthritis. Now, this is type 4 hypersensitivity. Okay. And just like we discussed already, I'm not going to harp on it anymore. You get production of CD4 cells. And since you got to think, remember, you have haptens presenting on cells, right? So you produce CD4 cells, you produce CD8 cells. And if you remember, CD4 cells can have different subcategories. That's where you get TH1, you get TH17 that do the job of causing the symptoms that you present with in a type 4 hypersensitivity. No antibodies are involved in this. Okay? Now, an example of this is something like poison ivy. So if you ever gotten poison ivy or any nickel metal allergy, you get exposed to it one day. Hours later, hours or even a day or two later, you present with a rash in that area. And then you may end up finding more spots later on popping up because essentially what ended up happening is you were exposed to the oil. The oil itself is not immunologic. It binds to proteins on your cells as a hapten, making them now foreign. and activating your adaptive immune response, right? And then by the time that immune response ended up happening, you had spread the oil to somewhere else on the body by accident without even knowing it. Okay. And that's why it shows up one spot and then you end up seeing more spots later because those other spots are now getting those haptens recognized. All right, great. Um, so just like I was saying earlier, right? This is a Th1, Th17 mediated pathway. Okay. That ends up destroying the actual tissue. Okay. And this is how you usually present. You get blisters. Blisters is a big thing you end up seeing if it's a type 4 hypersensitivity. All right. Any questions on the hypersensitivities? Okay. There is one other thing I didn't add in here that I can talk about real quick. The other thing is TB. So, TB injections is also a type 4 reaction because essentially what you're wanting to see is, does this person have a Th1 immune response? Okay. So, if you remember, Th1 deals with intracellular pertaining to macrophages, right? They release that interferon gamma to cause macrophages to have a better respiratory burst to kill off whatever they have inside of them. Okay. Now, TB is essentially injected into the tissue. You have T helper 1 cells present in your tissues, just chilling out, right? And they can get exposed to this as well. And as a result, they reactivate. TB is a hapten that they use, and it does exactly the same thing that we've discussed. It binds to the actual cells, so then Th1 can go in and cause the reaction. All right. Any questions on that? TB is a type 4 hypersensitivity reaction. This one, once again, is very easy for people to pick up because people tend to say, okay, if it's longer than a day, most likely it's type 4 hypersensitivity, if it's a question. If it happens immediately, most likely it's a type 1 hypersensitivity. You get the rash, it's very itchy. Sometimes you get throat issues. Everybody have seen or heard of anaphylaxis. But type 2, type 3, people mess up a lot. And those are the questions that professors love to give. Because if you can't get it, then they're going to get you on it. And that's how they weed through who knows the material and who doesn't. Okay. So really focusing a lot on type 2 and type 3. All right. Now, transplant. Let's talk a little bit about this. Transplant is not as bad because we're just building up now. So with transplant immunology, you essentially have to do two things. One, you need to see the blood groups. Do the blood groups match? This is because blood groups are not just noted on RBCs. Blood groups are also noted on the endothelium because you got to think like this. Blood groups are essentially antigens that are glucoses, right? You guys went over blood groups when you did the first year material. So it's essentially antigens that are presented on RBCs that are your antigens, right? And you produce antibodies for the opposite. So for instance, if I'm A positive, right? What antibodies do I produce? So if I'm A positive, the antibodies that I produce are B, right? So I'm going to produce antibodies for the opposite blood type. For instance, if I'm B, I'm going to produce antibodies for A. If I'm O, I'm going to produce antibodies for A and B, right? Now, these antibodies are also going to react with your blood vessels because your blood vessels are in the same vicinity. So it makes sense for them to also have the same blood groups, your blood vessels. Does that make sense? So not only do the red blood cells have that antigen, but also the actual endothelial lining. Okay. Now, the second thing you got to think about is the HLA component. We've already gone over this many times, HLA. These HLA components are noted on all cells, type 1 or type 2. Type 2 is noted on your APCs, right? Your macrophages, your B cells, your dendritic cells. Okay. So those are the two things you figure out and cross match with someone to see if they're a good match. Now, my next question is this. If you had an issue with the ABO blood typing, do you think you'd have reaction right away? Yes. So what I just explained to you is what is known as the hyperacute stage. You have preformed antibodies. Okay. Um, so don't think of anaphylaxis because now we're not thinking about hypersensitivities anymore. This is organ transplantation. Okay. This would be deemed a type 2 hypersensitivity. Because once again, remember, if antibodies bind to cells, it's type 2. You see how it's confusing, and that's why people miss type 2 and type 3. So antibodies are binding to the actual endothelial lining, causing damage, and it's happening immediately because you already have these preformed antibodies. Okay? Now, what ends up happening is you'll see in the vignette that there is what is known as thrombosis. Thrombosis just means that you have complete occlusion of blood flow to the organ that you just transplanted. It literally happens like on the operating table. You take out the organ, you put the new organ in before you can even sew them back up. That organ is pale, it's thrombotic, it's dead because it's that quick of a reaction because you have these preformed antibodies that quickly bind to these vessel walls. And when they bind to the vessel wall, you got to think you have complement here that can bind. And that leads to massive thrombosis. Okay, good. So that's hyperacute. Now, the next one is acute. So after you get the ABO blood typing matched and it's perfect, then it's not so much hyperacute. Hyperacute is off the table now. This is ABO blood typing. This hardly ever happens anymore. It's more likely to occur in someone who is a woman who has multiple pregnancies because she's exposed to multiple blood types throughout the pregnancies. Okay, so those women are more likely to have a hyperacute reaction versus people who are just, running the mill. However, the next one, acute rejection. Acute rejection is now more looking at MHCs. This and on. is MHCs. Okay? Do your MHC match? Okay? With an acute one, they don't fully match up. So as a result, you produce CD8, CD4 cells that then damage the cell lining and cause issues. Okay? Now, with the next one being chronic, in this one, you're essentially having this breakdown now of, once again, these T cells doing the same thing, right? So you have CD4 cells, the more prominent ones, while in this one, it's more CD8 related. Okay. CD4s can be present in here, but it's more CD8 related. And here it's solely CD4. So no longer CD8. Okay. And what essentially ends up happening is you end up producing these markers or cytokines that causes the actual blood vessel wall to hypertrophy. And this hypertrophy or proliferation makes the lumen small. And if you remember back in cardio, what happens when you make the lumen smaller? What ends up happening? You increase pressure. And what do you do to flow? Blood flow. Yes, this decreases. And this is why you end up having to replace that organ. Because eventually it decreased blood flow. That decreased blood flow then causes fibrosis and ischemia of the organ, and it's no longer going to work properly. Okay? So that's essentially what ends up happening. All right? So those are the different types of hypersensitivity, not hypersensitivity, but organ transplant rejections. This is where treatment comes into play, acute. There's not really any treatment for chronic. No treatment. We can essentially slow down the possibility of you showing up in chronic, but eventually you're going to need a new organ because chronic will eventually come and you're going to need a new organ. But we can at least stop the acute from occurring so it can last longer until it reaches chronic. Does that make sense? Okay, great. Now, here is showing you the same thing, but now in first aid form. I want to say this is, I'll tell you the page here in a minute, but essentially what's ending up happening here is that you're looking at the timeline. This is the big thing you want to do is look at the timeline when you're doing these rejections because the timeline is markedly different. For instance, with a hyperacute, like I was saying, it's very immediate. It happens right now, like in the operating room, right? Versus acute, what happened later on down the line, up to about 6 months or a little bit longer, but it's well past the initial transplantation time. Okay. Excuse me. And then finally, you have the chronic. And in chronic, this is where you're like long term, like months on, like to years. Okay. So these are the different breakdowns of how you can utilize them and separate the two of them. Okay. So this is noted on page like 112 of your first aid book. Okay. Now, the last one I'm going to talk about is this graft versus host disease. So this guy, essentially what ends up happening is this. In graft versus host, the donor person still has antibodies, or not antibodies, but CD8 cells and CD4 cells. So we'll do a liver. And inside the liver, you still have CD4 and CD8. You have B cells present here. All these cells from the donor. Okay? What ends up happening is you take this liver and you transplant it to the recipient. Now, as a result, some of these guys stay and you still get inside the recipient. You can wash it out as much as you want. No matter what, you're still going to have some of these CD4, some of these immune cells still popping up in the recipient. Okay? So essentially what ends up happening is these CD8 and CD4 cells, they go and they attack the recipient's WBCs. Now, they attack at certain locations. Now, if you remember, CD4 and CD8 cells, but mainly CD4 cells, they present which type of MHC? MHC2. Perfect. Now, my next question is this. MHC2 is noted on what type of cell? Normally. MHC2 is noted on what type of cell normally? Antigen presenting cells, right? So we're thinking macrophages. We're thinking B cells. We're thinking dendritic cells, right? We're just going to focus on macrophages and dendritic cells right now. But macrophages and dendritic cells, where do you find them? Where do you find macrophages and dendritic cells? Yeah, they're in the innate system, but do you find them in the blood? Do you find them in the tissues? Like, where do you find them in the tissues if you even were to find them in the tissues? This is very important because this is going to help you identify where you're going to see symptoms. So you find them in the tissues, right? Particularly things like skin. You find them in areas like the Peyer's patches in the GI system, right? These are the locations that you find them. So what ends up happening is these are the areas that end up getting damaged. Look, maculopapular rash, because they're damaging the ones in the skin. Diarrhea, because they're damaging the one in the intestines. You also have them in the spleen. Remember those, the white pulp, right? So you get hepatosplenomegaly because it damages those guys and targets those guys. And just like I said, liver is also where you have these guys. So these are the locations that you show up symptoms. Okay, because they're targeting these these MHC2 presenting cells. Okay, now the only way you present with this is if you get a bone marrow transplant or liver. More commonly than not, they give you an example of a bone marrow transplant. Okay, the reason why is because when you do bone marrow transplants, you completely eradicate the recipient's normal bone marrow. So that means he has no white blood cells outside of the innate that are already in the tissues. Okay. So when you give them a new bone marrow, that's going to completely replace his already depleted white blood cells. So that's why you usually see it in bone marrow transplants. Okay. All right, good. Now, immunosuppressive drugs, there's a lot of them. You're going to have to go over them. And there's no real trick to this. I'm sorry, there's no real trick to this other than making sure you understand what you're trying to prevent, right? So for instance, we're trying to decrease IL-2, like we discussed. All these guys do that. Tacrolimus, cyclosporin decreases IL-2 production. Sirolimus decreases the response to IL-2. So this is if you've already made it, this prevents you from allowing it to send the internal signal. Now, these here, daclizumab and basiliximab, these guys are the same concept. They're preventing the response to IL-2. And then the last guys are these guys, azathioprine and mycophenolate. These have to do with decreasing purine nucleotides, so you can't do DNA replication. If you can't do DNA replication, you can't make new cells. And then the last thing has to do with NF-kappa beta. If you remember, all these pathways we talked about, you send signals down in CD3 on the T cells get activated. They send signals down and they activate NF-kappa beta. That's why glucocorticoids would inhibit it is also a substance that you can use for immunosuppressant. Okay. And once again, this is just to prevent acute. Okay. You prevent acute so you can reach chronic. And then when you reach chronic, you have to get a new one. All right. Okay. Now, this is where Sketchy came into play. It's a very good tool you could use. They have different things on here that help you to identify or help you memorize what each drug does. I did Sketchy for the first semester, Med 3. I did not do it for Med 4 because I don't know. For me personally, I had a harder time with it because you have to not only memorize the drug, but also memorize what the heck this means, what this means, what this stuff here means. And then it makes it more confusing. But this is also a good tool though for condensing the drugs. Okay. So what I mean by that is this. This video here, for instance, has to deal with NSAIDs. Right? So everything about NSAIDs is in this video. So it really condenses it all down for you. So you don't have to keep looking and finding other things, using other tools. So that is why I found it very nice, is that it allows you to kind of condense things down. But yes, so that's how that is set up. Here's another one. They have a video for glucocorticoids that you can watch. Same thing. Immunosuppressive drugs, unfortunately, they don't, what you know already. So we're just going to keep moving on. Okay, now transfusion reactions. I'm not going to spend too much time on this because you may see at most one question on this because they don't really talk about it too much for your class. But you will see questions on this on your step. So I'm just going to quickly go through it. But essentially what all it is that you have different transfusion reactions based on what is being affected or what is being targeted. Okay. So for instance, if you have RBCs being targeted, that is what is known as an acute hemolytic transfusion reaction. Okay. Since you're binding to the actual RBCs, this is a type 2 hypersensitivity. Okay. And you present with certain symptoms like fever, hypotension, hemoglobinuria, because the red blood cells are being bursted open. So red blood cells have hemoglobin in them to bind to oxygen, right? So when you burst them open, that hemoglobin gets released into the blood. All right. And as a result of that, your kidneys do not like hemoglobin. It's abnormal for your blood to have it. So your kidneys don't like it. So as a result, when they get hit with the hemoglobin, they get irritated and you get flank pain. Okay. So that's kind of how this thing is presented. I'm not trying to harp too much on this because once again, this isn't really highly tested on your test that you're going to hit. It's nice to know moving forward, but this likelihood of it being on the test is very slim. And if it does, it's like one question. Now this one here is very important when you get to Med 4, when you start looking at the lungs. Okay. Essentially what's happening here is you have this reaction due to antibodies being present and white blood cells being present in the donor blood. Okay. So you give that in the donor antibodies, then target your host white blood cells in the lungs, which causes them to become activated and causes you to have symptoms of inflammation. And what is the big sign of inflammation? Edema. Don't worry about the pulmonary portion because you'll get there, right? But edema is a big symptom. Yeah. Okay. So we got the primary immunodeficiencies. I kind of don't want to move any faster through this because if we do that, I feel like we're going to skimp out on a lot. The big thing I will say is this. This is a food for thought that we will then touch on Thursday. Okay? T cells. You already know their function, right? You have T helper cells, you got CD8 cells. Now, CD8 cells are very good for killing viruses, right? Th17 cells are very important with bringing in neutrophils, as well as Th1 cells are very important on activating macrophages to eat things properly. That is why when you have damage to T cells, solely T cells right now, you end up with increased virus infections and increased fungal infections. You do not have an increase in bacterial infections. Okay? So what I mean by that is this. The patient will not present with excessive purulent infections because purulent infections are bacterial, right? So the likelihood of you showing up with those is very unlikely. You will show up with more fungal and viral infections. Now, if you damage B cells, solely B cells, you end up presenting with different symptoms. If you remember, antibodies are very important for binding to bacteria for opsonization, as well as binding to bacteria to allow complement to be activated to then kill off bacteria. So if you lose B cells, you lose the aspect of antibodies and you get a higher propensity or higher susceptibility to bacteria. Okay, that's the first thing. Now, the second thing is these antibodies, especially IgA, is lining your mucus in all your oral cavities your mouth, your GI system, your vaginal system, all of those areas. So things like parasites that anchor onto your mucus linings cannot do so because antibodies are there, right? Viruses that anchor onto those linings as well cannot do so because antibodies are there. So that is why you have an increase in viral and parasitic infections. Giardia, the image, the word I have here, Giardia is a parasitic infection, okay? Which you present with watery diarrhea, or not really watery, but it's like very fatty diarrhea. It's called steatorrhea, which you'll learn about later. But it's very fatty, foul-smelling diarrhea. Okay? Now, the last thing is this. Your T cells are normal, right? So you can still produce Th17 cells and Th1 cells to activate macrophages to eat up funguses. This is why funguses are not an issue. Okay? With mixed, you get all infections because you don't have any of them. Okay? Does that make sense? Okay. That's the food for thought I'm going to give to you now. You can take that and you can run a little bit more with it by looking over these conditions. Um, the last thing I'll kind of throw out there too is complement, right? We harped on it really big. Complement deals with two things. One, it deals with opsonization of bacteria, right? With C3b, utilizing that pathway and forming the MAC complex with bacteria. Okay. But in particular, right, is gram-negative bacteria that we said. The other thing that complement deals with, which is where the early complement deficiency comes in play, is with opsonization of immune complexes. So if you have a deficiency in early complement deficiency, it would be expected that you see an increase or rise in immune complex deposition. This is why people who have early complement deficiency present more likely with SLE, which is something that you'll learn later, which is lupus. Okay? So that's kind of how these guys are broken down. Any questions on any of this stuff? This is how you're going to attack these questions pertaining to these different deficiencies. Because every one of these patients is going to show up with recurrent infections. All of them are going to show up as little kids or young adults. All of them are going to show up with failure or having an issue to gain weight. Some are more likely to show up with failure to thrive, which is when they just can't survive and they're not growing properly. That's with mixed. You see that more with mixed, but you can see it with others. All of them are going to show that way. And then they're going to say, okay, which one of these is most likely the condition? So that's why it's very important to make sure you know if this is virus, do I see fungal? Do I see parasitic infections? Or do I see both? Okay, this is what I should be thinking. It's a mixed. I should be thinking more B. I should be thinking more T's. Okay? All right. All right. Well, I'm sorry that I wasn't able to finish the whole PowerPoint. I mean, we got pretty much at the end. There was only a little bit left. I apologize. Um, but we were able to get to the very end, at least to close to it. So on Thursday, we'll have questions. We'll go over questions. I want you to, because I'm going to have questions even on these guys, right? Because I want you to focus in on this. Let me get my marker. I want you to focus in on this right now. Okay? Really focus in on that. Because when we do questions on Thursday, I'm going to point this out a lot more. And then when I say things like, oh, this is a viral fungal, no parasites, no bacterial infections, and I ask you guys what diagnoses this can be, I want you guys to be able to tell me these names. You don't have to memorize what they do yet, but at least have an idea of what diagnoses it can be. Okay? So then you can then expand more on it by reading up on what each syndrome is. Okay? Because they all have the little nuances with what is affected. But if you're able to at least do this first part and you know what diagnoses are related to each one, you will be golden. Because all you then have to know is just the details of the diagnosis. And that's just taking time to review the material. You're no longer having to reason through the material anymore. It's just, do you know it or do you not? Okay. That's where I'm trying to get you guys to be at. It's either you know it or you're not. I don't want you to be like, well, I just don't understand it. I don't know where to approach this. This is going to allow you to know how to approach it. Okay. Good. All right, guys. Yeah, I mean, that's it. There's nothing more. I hope this was helpful. I'm going to make the rest of it on Thursday. I feel like I'm always going over with lectures. I don't think there's ever been a lecture so far that I finished on time and there was no more.